Hello, everyone. Welcome back to another episode of Behind the Counter with NJSHP, a podcast that takes you outside the classroom and into the real world of pharmacy practice. My name is Shao Dwan, and I'm one of NJSHP's Public Relations Project Chairs who works alongside CM Majumder. In each episode, we talk with pharmacists from different clinical specialties to give you a closer look at what they do, how they got there, and what it's really like. In this episode, we have the pleasure of speaking with Dr. Antoinette Acbo, an infectious disease pharmacist at Jersey Shore University Medical Center and clinical assistant professor here at the Ernest School of Pharmacy. We talk about her journey to where she is today and her experience as an infectious disease pharmacist and professor. We speak on the role an infectious disease pharmacist plays in the healthcare setting, the things they constantly worry about and deal with, such as antibiotic resistance, and also we talk about antimicrobial stewardship and much more. Thank you for listening to this episode, and we hope you enjoy. Thank you so much for being here today. So for our first question, can you just tell us about yourself? Like, how did you get to where you are today in your role?
Yeah, sure. So basically, I went to Albany College of Pharmacy and Health Sciences. Then I did a PGY1 at the Hampton Veterans Affairs Medical Center in Hampton, Virginia. So I was like born and raised in New York, but wanted to see what patient care looked like within the VA system and within like a different part of the country. And then after doing my PGY1, I decided that I wanted to pursue infectious diseases. So I completed my PGY2 in infectious diseases at Montefiore Medical Center in the Bronx. And now I'm here.
Wow, that's really nice.
Thank you.
I wanted to ask, I feel like infectious disease is a very niche specialty. So I was wondering what originally drew you to choosing that specialty in pharmacy.
Yeah, I think so. Really, my first exposure, you do your classes and you get your therapeutic modules. And I really liked my ID professor. So I signed up to do a rotation with him. And it was at the VA in Albany, actually. And basically, within the first week or so, he had us making calls to different providers to say, like, can we de-escalate this therapy? Can we consider discontinuing therapies? And they were just doing it. They were like, yeah, that sounds like a great idea. We will do that. And I really loved kind of having that direct role in patient care. But despite that, I thought I was actually going to be an amp care pharmacist. So that's why I went to the VA. And I think all of my preceptors could have told you I was going to be ID because all of my research projects and all of my like educations I was doing was ID focused because I thought I would never get to do ID again. But then I decided to pursue that after kind of like really thinking about it and realizing that I was like reading guidelines for fun after PGY1 rotation. And I was like, oh, maybe this is actually what's for me. So that's kind of the whole pathway.
Mhm.
Interesting. Reading guidelines for fun is wow. That's
Yeah, I
crazy.
don't do that as much anymore.
Still, that is very admirable.
Yeah.
So I'm sure you like now that you spend time here at Rutgers, I'm sure you realize like how kind of industry focused Rutgers is compared to some other pharmacy programs. So I guess for you, why did you choose to go down the clinical route rather than industry? Yeah.
Yeah, I think that for me, honestly, I didn't know much about industry in the first place. But after kind of doing a few appies, I really loved working with a team and collaborating with providers to try to make the best outcome for the patient. And I really, really liked the puzzle of like taking care of patients and seeing what we could optimize. And I knew that I couldn't necessarily do that in industry, though I totally acknowledge their role that they play within like optimizing care for patients long term. I think for me personally, I knew that I wanted to be like in there, getting my hands dirty and like participating actively in the care.
hmm Yeah. I also relate to that. I feel like coming into pharmacy school, I was also very I'm still a PP2, so I don't know for sure. But I've definitely feel like I want to do something more patient revolved and patient focused. But I don't know. A lot of people do industry here, so we'll figure that out later. But so we were wondering, what's a typical day-to-day basis looks like for someone that works in for ID clinical pharmacist at Jersey Shore University Medical Center specifically?
Yeah, so essentially, my service has about like 40 to 50 patients when it's like the busiest. Um, Fortunately for me, I only look at the infectious diseases parts, right? So I just have to manage antibiotics. I don't have to do like insulins and other things like that. So basically, my morning is spent pre-rounding on the patients and making sure that at least I'm checking like their dosages. I'm making sure that there are new updates to cultures, and we're like optimizing therapy based on those. So whether it's de-escalating or escalating therapies, often I have students with me. So then I pre-round with the students and kind of vet their interventions. Then we all go together to patient care rounds, and that can look a little different depending on the team that we're working with that day. So our team sometimes likes to do bedside rounds, and we'll walk around the hospital for like 2 to 3 hours talking about patients. And then other times we'll sit in front of a computer and get rounds done in like 15 to 20 minutes. So it can look very different on the day to day.
Mhm.
But then after rounding, typically we'll do like topic discussions, or if I don't have students, we'll be working on different like policies and projects within the network in collaboration with some of our other ID pharmacists. And sometimes that also involves working with like multidisciplinary teams like infection prevention and our microbiology labs as well. So there's a lot of different pieces. And then hopefully by the end of the day, I also get the chance to look at our antimicrobial stewardship lists too, where we basically look at like all the patients in the hospital on antibiotics and see what we can kind of optimize from there.
That sounds like a lot to do in one day.
I don't get through everything, but there's many tasks to be done, certainly.
Mm.
Yeah.
I was wondering more specifically for when you pre-round,
Mhm.
because like as I'm going through like the modules as a P2, I'm learning there's the antimicrobials, there's a lot of drug-drug interactions. So for pre-rounding, like what is, I guess like how much time or how much effort is needed to kind of go through those interactions?
For drug-drug interactions specifically, I find that they are probably the most time-consuming, because very often, like I know which drugs are going to have that type of flag, and oftentimes I turn to Lexi and plug every drug in, and then I look and see if I think that it's a severe enough interaction to bring up to the team. So it's a lot of clinical judgment when it comes to the drug-drug interactions. So that can range from anywhere between like 10 to 15 minutes depending on if I'm like already aware of what the interactions are. And sometimes it requires me to do a little background search to see how severe some of these things really are.
Oh wait, I'm gonna jump around a little bit. I know you mentioned your antimicrobial stewardship. So I was wondering like what exactly is that and like why pharmacists or why why are pharmacists central to these programs?
So essentially, antimicrobial stewardship is the idea slash the service where we try to optimize antimicrobial use and ensure that it's as appropriate and as optimized as possible. And that usually revolves around like appropriate dosing, appropriate durations, appropriate routes and spectrum of antibiotics. And oftentimes it's done with the goal of reducing both individual and institutional rates of adverse effects for patients, like, for example, like C. diff, diarrhea, and also trying to reduce the amount of resistance. Ultimately, I think the reason that pharmacists are pretty central to this program is because pharmacists are very much detectives. And I think you'll find that as you progress through your curriculum and through your APPEs. And I think like providers have a lot of different responsibilities, right? Like our job is literally just the medication. So when it comes to the antibiotics, we have the ability to say like, oh, I know exactly what this covers. I understand the PK. I understand what the dosing should be. And we have a little bit more nuanced approaches when it comes to looking at all of these minute details. Whereas they may see like that drug covers that bug, and that's sufficient for me to get through what's going on. And I think there's like a lot of different things that they have to juggle. So I think we kind of have the opportunity to slide in there and see like, oh, can this patient tolerate PO therapy? Switch them off of IV. Are they on duplicate therapy? So I think pharmacists just have kind of more of a little background role where they have time to look through these more nuanced things.
Hmm, interesting. And then you talked about kind of the spectrum for the antibiotics, when it comes to prescribing or kind of like figuring out what antibiotic to use for these patients, how do you know whether or not to use like a broad spectrum antibiotic or like a more specific antibiotic? And also, how fast and how much time do you have to kind of make that decision because of the fact that resistance can occur very quickly. So, how much time do you have to really kind of make that decision?
Okay, so to start off, I think with regards to deciding when to use broad spectrum or narrow spectrum agents, it's really part of how your patient's doing, right? So if your patient is in the ED, they're like super hypotensive, you're going to start pressors on them, like all these things, and you're kind of acting rapidly on them. We typically tend to give them really broad spectrum things. So in the ED on your rotations, you're going to see that these patients get piperacillin tazobactam and vancomycin because these are really broad spectrum gram-negative and gram-positive agents respectively. So they're going to try to hit them with whatever they can in hopes that they covered the thing. But if you have a very stable patient, for example, like a lot of patients with like diabetic foot infections are really clinically stable. So sometimes we'll wait to give them antibiotics, even though it might look infected, because we'll wait to see what the culture comes back as. So we know that we can target therapy. But regardless, even in those cases where we slam the patient with broad spectrum antibiotics in the ED, it's almost as important to get the relevant cultures, right? So blood cultures, urine cultures, whatever, so that we can narrow therapy when the time comes. But a lot of that comes down to patient specific factors and how they're doing in the hospital. And then, wait, sorry, what was the second question?
I guess the second question was like how much time or like
Oh,
how much of a rush is kind of switching from broad spectrum to narrow spectrum.
yeah. So we always say that de-escalation is never urgent. It
Mhm.
is something, like you mentioned, resistance is a big issue. But at the end of the day, if a patient looks like they're really not clinically doing well, the last thing we want is to too aggressively switch off and to de-escalate. So actually very often we'll take our time with it. If the patient's clinically stable, I'm very pro de-escalation. But we also have to work with the team to understand what their concerns are and whether or not they feel like it's the right time to make that type of move. But I love ID because it's something that moves a little slower.
Mm. Yeah. It seems like there's like a lot of like decision making involved and like on the spot. So we were wondering like how do you in this specific role like how would you handle like any disagreements with like providers or like how would you communicate with them if like you didn't agree on something?
Yeah, I think that's such a good question. And I think actually a lot of students struggle with it when they're on rotation because we teach you guys how to like optimize therapy. We're like, read the guidelines and know the best thing to do. And I think really the biggest thing is to try to A, bolster your interventions with as much evidence and with your rationale and make sure that you've really thought about this and really anticipated what questions your team may have, right? Because the more prepared you come off, the more willing they're going to be to trust you and the decision you make. But I think more importantly, like beyond that, if they really disagree with you, you have to remember that everyone is theoretically coming from the position that they want the patient to have the best outcome. So no one's coming and saying, like, oh, I really hope that patient gets hurt, right? Everyone's just trying to make sure that the patient is safe. So sometimes providers may see something that I don't, especially on antimicrobial stewardship. A lot of the times it's driven by looking at reports and like looking through the patient's charts and not necessarily going to see them in person. So sometimes they see like, oh, the patient looked clinically worse today. The nurse said they're not tolerating any PO meds. So sometimes they see some of these things that I don't have the ability to see because, we're trying to manage a lot of different patients. So I can't go to every single patient in the hospital that day. And sometimes if it's really bad and like you really think it's a safety issue, you can always try to escalate. So I always say if it's like a learner, so a resident or a fellow, you can talk to their attending. If it's an attending, you can reach out to your stewardship director and sometimes they can have your back and try to intervene because sometimes it's a matter of disagreement. But at the end of the day, everyone's trying to take care of the patient.
Hmm.
Right. And I guess when it comes to those decisions, and also like as a pharmacist, do part of antimicrobial stewardship, what is like the most common mistake, if you can call it that, or like most common like inappropriate like decision making you've seen from providers when it comes to antimicrobials?
I think something that we see a lot is treating a positive urine culture as a UTI. So
Oh,
when you get through your your ID modules, and when you get through your rotations, you'll note that a lot of providers were taught, and even I was taught in my ID rotation, that an older patient who's confused probably has a UTI. But we actually have guidelines from the Infectious Diseases Society of America to say that they probably don't have a UTI, and you should really look at other reasons that they might be confused. But more often than not, we throw antibiotics at those patients anyway and they probably need 0 days of antibiotics and usually end up getting 3 to 7. And it is really hard sometimes to convince teams, especially when they were taught this like confused patient equals UTI dogma very early in their careers, right? It's a lot of
mhm.
education and trying to get them to understand, like, well, they're here and we can monitor them to see how they do clinically, but probably. treating asymptomatic bacteria.
Mm, okay.
Mm.
Speaking of education, how well does, or I guess not how well, but how applicable is the stuff we learned like as a PTO, like in our modules? How well does it apply to when we go orientation and actually help kind of with making like maybe antimicrobial decisions? Because also, because as we know, like again, resistance is something that's changing constantly, right? So by the time I probably get to my appies, which is just 2 years, I'm sure there's going to be a lot more new um, multi-drug resistant microbials than there are now. So how applicable is the stuff that I learned now going to be in the future?
That's a great question. I think for the most part, when we're teaching you in modules, we're teaching you like broad information, right? So if you end up being like a generalist, it's still something that you're going to be able to utilize. So very often we're teaching you like big disease states, right? We're teaching you like pneumonia, we're teaching you urinary tract infections, we're teaching you skin soft tissue infections, we're teaching meningitis. And all of these things, the first line agents, if patients are coming from community, will probably be the same is my hope and my dream for you when you get to appies in 2 years. But certainly, I think the bigger piece of treating infectious diseases sometimes is understanding your local resistance patterns. So, any institution, like any hospital that you're working at, really has to have their local antibiogram, which is literally like a table that shows for all of these, or for like most of the common organisms, what were the resistance patterns to most of the most common antibiotics. And so I always try to tell students, like, yes, the guidelines are absolutely where you should get started. But as you progress, I want you to look at the antibiograms and I want you to look at your patient's specific cultures and susceptibilities to really get an understanding of how to treat. So I'm going to say the stuff we're teaching you is very relevant still, because empiric therapy is always probably going to be very similar. But when you get to appies, your preceptors will probably do their best to update you on some of the things you learned too.
Mhm. Yeah, I'm quite far from my appies, but I'm taking integrated organ phys. That's my first actual pharmacy class, but I can't wait to like get that experience, like actually being hands-on. Um, but we also know that you're a clinical assistant professor here at Ernest Mario. So, what inspired you to also get involved in academia and in addition to your clinical practice?
So I kind of knew that I wanted to teach from a young age. So I like when I was in like middle school and high school, I wanted to be like a music teacher, and then I wanted to be a chemistry teacher. And then when I went to pharmacy school, I wasn't really sure what type of pharmacy I wanted to do. So, when I went to pharmacy school, I thought I would literally only get the chance to be a retail pharmacist, and they're like so important. Like I worked at CVS for many years. My heart goes out to them. They do a lot of the important work and the day to day. But I knew that I was not strong enough to do it truly. Um, and I realized, particularly after precepting in my PGY1 and PGY2s, I like loved working with the students and I loved seeing like the parts that they didn't really understand and being able to break the big concepts down for them. And I like tutored and stuff throughout college as well. So I always had a little bit of the teaching bug in me, I think.
Mhm. What specific courses would you say like go over these specific topics or like what year? I'm just
Oh,
wondering.
so I kind of teach around. So I teach in like foundations of pharmacy. So I try to get like the basis of the PK and all of that stuff. But I'm sure that by the time you get to P2, your brain's been so overloaded with all these things. So I think that like the actual antimicrobial or the actual infectious diseases module does cover a lot of the big topics, but sometimes there's so much for us to cover. We're often relying on you all to do kind of like your homework and further investigation and independent research to make sure that you understand the why behind things. Because I think it's really easy for us to get caught up in like, hi, this is what you need to put on the test next, you know? But I want to make sure that you understand the why, especially once you get to like your appies.
Mhm. That makes sense. Circling back to kind of why you chose to be a professor, I relate to that too because also I do like teaching and also I coach volleyball at my high school or
Mhm.
the high school I graduated from, and yeah, teaching and just like coaching is something I like a lot. But one of the biggest issues as to why I kind of like scared to try to pursue a route that would allow me to be a clinical assistant professor is the biggest issue of balance because I'm wondering like how do you balance being both a professor and a like clinical pharmacist, especially with ID, because it sounds like there's so much you have to do. How do you balance it? And how do you still kind of keep yourself going and prevent like burnout?
That's a great question. So I'm still relatively new, and fortunately, I think Rutgers does a really great job of balancing, especially for new faculty. So I would say I'm right now more like 90-10 or like 80-20 at the hospital mostly. And for new faculty, that's like the expectation because you're trying to set up your clinical site, you're trying to establish your rapport with your clinical team and like your pharmacy department and like making sure that they know who you are and what you're there to do and like what your students are there to do. But in terms of like, as I am picking up new things and like trying to get more involved in other professional organizations, I think the big thing is like open communication. So I have like a really great pharmacy team. I've got like a great co-ID pharmacist at Jersey Shore. So a lot of it is just saying like, hey, I'm not going to be here today, so I might not be able to get through XYZ. I'm just letting you know ahead of time, but I'll try to address that tomorrow. Or if there's something urgent, of course, feel free to reach out to me. So I think it's really just the communication piece first and foremost, and then trying to set those expectations so no one's disappointed, right? That I didn't get to do the stewardship list today because they know that I was at the school teaching on that day. So that's probably like my biggest piece right now. But I think also talking and learning from more senior faculty has been really helpful to understand that like I should really say yes to things that I feel passionately about and try not to overload my plate with things that I'm doing just to like pad my CV. And that's advice that I would give to anyone is like do things because you love it, not because you feel like you should be doing it.
Mhm. Yeah, that's very advice. Are there like some ways that you wind down when you have your free time at home?
I love to like eat ice cream, so I'll do that with like my coworkers after work.
Mm.
And it's like a nice time to like talk about what happened at the hospital that day, HIPAA compliant, of course. And I also like to like play video games and music and things like that. So
Oh.
it's kind of a nice way to
Mhm.
step down from the hospital.
Yeah. Wait,
Nice.
this is a little off topic. Do you play a
Sure.
specific instrument or
Uh, yeah, I actually play the clarinet. So I
Oh,
played
okay.
like, you know, when you play in like elementary school.
Yeah, yeah.
So I played a little bit like all the way up through college.
Mm.
Didn't play in residency, but there's actually like a local concert
Yeah.
band that I play in.
Oh,
Yeah, so it's kind of fun.
okay. Wait, that's really nice. I all of high school, like I just did band. I played French horn.
Oh,
So
love.
yeah, I was a brass person, but like yeah, that was definitely something like I used to like wind down. That was like the one thing like when I'd come home from school, like I would just play French horn because I feel like that was like a way to like decompress. But I
Totally.
just wanted to know.
Yeah, clarinet.
I feel so out of place. I was a choir boy. I feel so out of
That's
place.
okay. I also sing. That's fine too.
Nice enough. But kind of going back to infectious diseases,
Mhm.
I'm wondering what is like the your biggest worry right now when it comes to infectious diseases, or I guess to make it easier for you, what's your biggest worry at Jersey Shore right now? Since I know infectious diseases changes like from location too. So just New Jersey, what's like the biggest kind of issue right now, you would say?
I think I'm gonna go pretty broad on this, but I would say like many times the focus of research is gram-negative organisms and gram-negative resistance, which is definitely a problem. Like there's a lot of multi-drug resistant Pseudomonas and carbapenem resistant Enterobacterales. But more concerning to me recently has been vancomycin resistant Enterococcus. So because we know that like multi-drug resistant gram-negatives are really bad, there's all these agents that have been developed and like novel antibiotics that have been developed for that specific indication. And there's like beautiful IDSA guidelines on like how to treat these things. But I think that our gram positives actually get neglected a little. And there's really only two agents that we use for vancomycin resistant vancomycin resistant enterococcus. That's linezolid and daptomycin. And I'm like a little nervous that we're going to lose these agents over time. But we have like a million gram negative options. That's not true. Maybe like 6 or 7 gram negative options, but not too many gram positive options. So that's kind of my personal fear.
That makes so much because that actually makes a lot of sense because just like last semester we did oh I guess I forgot what class, but we learned about a lot of different organisms like different bacterias and then also recently during medchem we're starting to learn a little more about antibiotics too. And as
Mhm.
I'm learning, I'm just like, there's so much stuff on gram negatives, but there's like
Yeah,
nothing for gram positive. I'm just like, wait.
that's what I'm saying.
Like, okay, it makes it
Yeah,
easy for me because when it comes to studying, all I have to worry about is gram negatives, but then I'm just like, what about gram positives?
yes, I'm concerned.
Oh, that makes a lot of sense. Huh. Like, and I guess like following up on that then is kind of what do you think will what will it take for people to kind of start focusing more on gram positives? Or what can we do to kind of help shift the focus?
I think probably, unfortunately, the answer is they're gonna not be able to develop a lot of things until it gets bad enough that we can't use these agents anymore. I think gram-negative resistance was very much the case before we got these novel antibiotics like cefiderocol and ceftolozine tazobactam and ceftazidime avibactam and like all these things for carbapenem-resistant organisms. We used like colistin and polymyxin B, and they're like very nephrotoxic agents. I'm sure you've probably learned. And it wasn't until those were our only options that we really started to like look at, what can we do? And I'm fortunate to have come into ID in an era where we have those options, but I do fear that we're going to wait a little bit too late
Mhm.
to address this issue. But in terms of how we can like shift the discussion, I think a lot of it is making sure that we're using daptomycin and linezolid responsibly within our institutions. Vancomycin is like a great drug, but sometimes providers don't always turn to it because course, they hate to monitor troughs. Like it's difficult. I understand. Trust me, I relate. I hated doing that when I was a student. I love it much more now, of course, but it's challenging. And I think when providers, are short on time, it's really a lot easier to go with daptomycin. But I think the short-term convenience of it sometimes is like a faster reward than the long-term prevention of resistance. So I think trying to really carefully and judiciously steward the use of dapto and linezolid is probably the best way that we can kind of move forward.
Mhm.
So like one last question to follow up. How
Yeah.
long do you think like that can last for where we kind of try to limit how much we use daptomycin and linezolid, lin, lin, lin,
Yeah, you said
linezolid?
it
I can't pronounce
perfect.
yeah,
Yeah.
linezolid.
I do not know how long, because to be honest, I don't really know how long it took for the gram-negative world to
Mm-hmm.
become the way it was, because that's like me being relatively new to practice. I will say, like, I've seen daptomycin-resistant enterococcus now. Like, I've seen a few isolates, and they're pretty resistant. And like, it sucks because linezolid, as great of a drug as it is, isn't an agent that you like typically want to use for a long time due to some of the toxicities. And it has a few drug-drug interactions as well. So sometimes when you have patients on meds with a lot of drug-drug interactions, the question is like, well, what are we going to do now? So I cannot give you a firm prediction, but I'm praying it's like 800 years from now.
Please.
Yes.
So, working at a medical center, obviously you're expected to work alongside physicians. So we were wondering, how involved are pharmacists in making antimicrobial therapy decisions compared to physicians or providers? And like, what kind of clinical questions do providers most often come to you about ID as a
That's a
pharmacist?
great question. I think I like antimicrobial stewardship, and I think it's so fun because basically any patient in the hospital that's on antibiotics can potentially be a patient that you optimize care for. But with that being said, I think like really pharmacists are making these decisions in conjunction with providers and prescribers. At the end of the day, it's not us, just like making changes willy-nilly. It's us having that conversation because as we discussed earlier, sometimes the teams see things that like I don't necessarily have the opportunity to see, right? So it's a lot of discussion with them. Um, and it really depends sometimes on the rapport that you have with the prescribers, right? You have to make sure that they know who you are and like what your goal is and what you're trying to do so that they remember that you also are aligned with their common goal of getting the patient out with the best outcome. But sometimes, like, because there's so much going on, they might not notice that a culture updated in the middle of the afternoon. And that culture may be an opportunity to de-escalate, but more concerningly could be something that you need to escalate therapy. So let's say it's like they're covering only for methicillin susceptible Staph aureus, and we see that it's MRSA. Then we have to go like, oh, I just wanted to reach out to you to let you know that this culture is updated. can we switch to vancomycin? And most of the time they're amenable to that, right? Because they know that you're looking out for the patient as well. But I will definitely say in terms of pharmacist interventions, probably like vancomycin dosing, aminoglycoside dosing, when to get levels. Like you mentioned, like drug-drug interactions. Those are probably the questions that we get the most. And sometimes they come to us for like, do you think that this is the most elegant therapy that we could use? So like we'll try to use like one agent instead of five different agents to cover one infection if possible.
Mhm.
So I was wondering from like a not a personal standpoint, but just like a more, I guess, personal standpoint. Like, how much does cost or money come into it when you make decisions for antimicrobial stewardship? Because I mean, because I don't know how expensive these drugs are. I'm sure some of them are cheaper, but then I said there are some novel antibiotics, so I'm sure those are a lot more expensive. So, how much does cost play a factor when it comes to making decisions?
I think personally, from my perspective, I care more about costs when it's related to the cost that a patient would have in terms of like actually accessing the medication. Of course, we know that some medications are cheaper in hospital. So part of the de-escalation discussion is trying to, provide cost savings to the institution. But once we start to get up to those novel agents, so for example, if like a patient started on cefiderocol for a UTI and I realized that um, they maybe could use an alternative agent that's a little bit more expensive, um, but more narrow, I might pull a trigger on that because to me, I think that the resistance is probably a larger cost down the road compared to like making sure that the patient uses the cheapest option, if that makes sense.
That makes sense.
Yeah.
Mhm. Yeah. I think that's like the best way to look at it, like prioritizing the patient. Um, but yeah, we also saw that you have a clinical interest in, sorry, I don't know if okay, immune compromised patients. So we're wondering what makes treating infections in immune compromised patients particularly challenging or different from a typical patient.
So I really enjoyed my like rotations in taking care of immunocompromised patients and like even doing so now because very often these patients are like in and out of the hospital for like whether they're immunocompromised for oncologic reasons or because they had a transplant at some point. They're already at risk for healthcare associated infections and like hospital associated organisms like Pseudomonas and MRSA. But I also think on the flip side of that, the literature is still like sparse, right, compared to our immunocompetent populations. So sometimes it's more difficult to convince teams to steward antimicrobials efficiently in these patients because they don't want to undertreat their patients because these patients have, we've invested so much time and effort and like care into them and making sure they get that kidney and making sure they get this like very expensive chemotherapy. The last thing we want is for them to like die from an infection. And I totally understand that perspective, but I think that's what makes it more challenging is like there's a lot of nuance to it where you really have to work closely with a team, but that's in part kind of what my favorite thing is, like working with the team to figure out what the best answer is for that specific patient.
My question is, when treating those immunocompromised patients, during your rounds, what's the, or I guess like just having during rounds with any whether immunocompromised or immunocompetent patients, what is it like kind of giving counseling to those patients regarding the drugs? And also, because I was wondering, do patients ever get like angry or just get agitated when during those rounds?
So admittedly, I feel like my role thus far has not had a lot of patient counseling. But the like handful of times that I've done it, it's oftentimes with regards to like penicillin allergies and their history with that. So kind of like trying to decode what's been going on or like trying to understand what they've been taking previously, and kind of like what their experience has been before hospitalization with us more than it is active counseling. But in all of my experiences with counseling patients, I think like, sure, some of them will get annoyed, but at its core, I think that's why it's so important to set expectations early on with them and say, like, hi, this is who I am. This is why I'm talking to you. My goal is for you to really have a good grasp of what you're leaving with here today. And I think if you kind of give them the empowerment to understand, like, this is for their benefit, I think it A, encourages them to listen a little bit more, but B, kind of helps to settle any nerves they have and kind of avoid some of that like irritation that can happen when they don't understand what's going on.
Would you ever choose to like start doing more patient counseling, or is that something like you're not super interested in? Or just wondering.
Yeah, I love patient counseling. I think it's more just like most of my patients are like acutely ill in the hospital and don't really want
Oh.
to talk. Um, but certainly I'm open to having those discussions. Like I very often tell my providers, like I'm happy to counsel patients on drug-drug interactions. We talked about like linezolid, for example, earlier. So one of the big things with linezolid is it can potentially cause serotonin syndrome with like antidepressants. It's something that we are trying to unteach providers as like a hard contraindication because it's not one. It's something that we can really monitor both inpatient and we can counsel patients on how to identify these signs and symptoms outpatient as well, and when to reach out to us. So I always offer to do that for them. I very often have discussions when I'm talking with patients. It's about like, hey, have you ever taken a penicillin? Did you know that you got a penicillin yesterday and you had no reaction? Would you be open to trying a penicillin? And very often they're like, oh yeah, I didn't even know I got that yesterday. Like, yes, I'd be open to doing that. And I think like it's such a small question to ask, but it has a really big impact, not only on like this hospitalization, but future hospitalizations as well. So I would definitely love to do more patient counseling. It's just about like the population at the end of the day.
Yeah.
Right.
I feel
What?
like, oh, sorry, you can go.
No, you go first. You go first.
Okay. It's just about patient counseling again. I feel like that's something like me personally would be more interested in. I feel like I always want to be like directly with the patient and like this was something like I was always interested in, like just working with the patient. Would you say like that's something like we get experience through like our appies like in our future years, or is it like outside of pharmacy school?
I think that really you can have a lot of opportunities. So, A, for sure on your appies, yes. Like if you're interested in patient-facing care, I would definitely say to make sure that you get a few ambulatory care appies on there. And there's a lot of different settings that you can do ambulatory care and like direct patient counseling. So whether that's like a heart failure clinic, whether that's an HIV clinic, there are a lot of different possibilities. So I would say like, yes, you absolutely have the opportunity. You just have to make sure you're picking the right rotations for it. And even like some of the inpatient rotations will have opportunities for that as well. And I certainly offer whenever there's an opportunity for like us to patient counsel, even though they're kind of rarer on my rotation, I always offer for the students to like do it if they're able to, and if they feel comfortable doing that. Um, but I think outside of pharmacy school, like certainly when I was an intern at CVS, I did a lot of patient counseling. And when I was even on my like community appies, I was, in the aisles, like answering questions, and the technicians love to be like, oh, we've got a student who can help you with that over the counter question. And I loved doing that stuff too, because that's like, it feels to us like low hanging fruit, like you feel
Mhm.
like, oh, yeah, you should definitely use this instead of this. But to the public, like they have no idea. They don't know that like phenylephrine doesn't really do anything for you. They don't know these things. So you kind of have the opportunity to be there for that person. And you don't necessarily even have to be in like a clinical setting for that, right? That's just like at your local CVS.
Mhm.
Speaking of the public, do you think the public or the general person knows how dangerous resistance is? Because you talked about how like when you talk to these patients about like their history, and then when you come to penicillin, it's kind of something they kind of just like yeah, sure, I did. I remember I took it. Like I don't know if I took it. Like, do you think that's kind of dangerous? And then like what steps do you think should be taken to kind of get people to realize like resistance is a serious thing?
That's such a good question. I think that the public is scared of organisms when they sound like they're flesh-eating organisms or like brain-eating amoeba. Like they're very afraid
Mhm.
of like buzzwords that sound like they're coming from a horror movie. I mean, they're certainly afraid of viral illnesses because of the pandemic, and I very much relate to that. But I think something that we actually struggle a lot with in the antimicrobial stewardship world is that a lot of the inappropriate antimicrobial use actually comes from like outpatient settings, right? So when, I'm sure if you worked at like a CVS or like if you're going to do that someday, you'll see so many Z packs get prescribed. And like most of those are inappropriately prescribed. And I think part of that is like this expectation that providers and patients have for each other. So patients go into the urgent care expecting to walk out the prescription for their runny nose and their sore throat and all these things. Even if it's a viral infection, sometimes you go into the doctor thinking you're going to get something at the pharmacy after that. And I think providers often feel like they have this pressure to prescribe something, even if they feel like it's a viral infection and maybe the antibiotics wouldn't be helpful. But you don't have a lot of time to build rapport in those settings, right? Urgent cares are very often like you're seeing this one provider one time and then literally never again. So it's easier to just give the antibiotic and have someone take it and not really see the consequences of that long term. But I think it's important to note like azithromycin actually used to be a really great option for like um, strep pneumoniae pneumonias, but we've lost that as an option because we give it to like everyone all the time. So I think the best way for us to kind of move forward in this piece is setting expectations with the public and like as a provider and as a clinician having those discussions about why it's important to slow down, to maybe watchful waiting is this term that they use in like peds ear infections, to see like is it viral, will it improve, and if not, like we can definitely give antibiotics, but I think patients are often scared to go home without something and not know if they can actually reach a provider again when they've already taken time out of their work schedule or their school schedule to like go and be seen.
Right.
Mhm.
Yeah.
That makes sense.
Wait, that's really interesting. We kind of learned that actually in like microeconomics. Like we were learning about like advertise. Wait, I know it sounds interesting.
No, I love
Yeah.
this.
What? How's
No,
econ? Okay, anyways.
we were learning we were learning about like advertising for drugs and since these specific drugs have been like being advertised like on TV and stuff, like patients would like think they would like self-diagnose in a
Yeah.
way, and then they would
Yeah.
like yeah, they would like ask for these. Like instead of like going to like with a problem, they would just be like, I have this problem because I saw it
Yes.
on TV. Like so
Yes.
it's just so interesting, like how like all these like advertising or like per patient perspectives. And like I understand like obviously when you go to like the doctor's office, like it would seem like a waste if there's nothing coming out of it. But like, I don't know, sometimes it's not necessary to have like medication all the time. Like, wait, now I'm just rambling. But like my parents, like they even like I appreciate what they say like about medication. Like they don't always, even when I'm like sick or something, we always try to do like natural remedies and stuff like that first. Okay. Like,
I
but
relate. I get
No,
it.
yeah,
that's so fair.
yeah.
Yeah.
I feel like it's important because like you don't want to like depend on these medications when you don't really need them because like in the long term like you don't know what like what would exactly happen. But
Yeah.
yeah, I just thought that point was interesting. But yeah.
Yeah.
Yeah. I guess one kind of following up about how like Z-Pack is overprescribed, and C was kind of talking about how people think they should come out of infection, come out of the doctor's visit or hospital with a prescription. But I guess other than those, what is like another like common ID like myth or like misconception you would say?
Hmm. Another common ID myth. Okay, so actually one of my like soapboxes that I sometimes stand on when students are on rotation is you're taught, and if you haven't already been taught, you will be taught that doxy is like not really that appropriate to use in pediatrics because
Mhm.
of the tooth discoloration and the bone growth, and like these are very legitimate problems. There are more so problems with tetracycline, so like the older cousin of doxycycline, but certainly still a concern. I relate to that. But something that I learned in my PGY2 was that some of the highest rates of death in rickettsial diseases, so think like tick-borne illnesses, where doxy is like first line, um, like kids have the like pretty low rates of getting these types of diseases, but have really high rates of mortality compared to other populations because providers are scared to treat them with doxycycline. But realistically, like, and I always say this to students, is like it's always about the risk benefit, right? And so, like, respectfully, at the end of the day, if that kid's gonna make it out alive, I'm okay with that over the risk of them maybe having tooth discoloration. And certainly, I understand the risks. Like, I understand the concerns with that, but I think like we really have to remember to always be like looking at the updated data, understanding the risk benefits of things, because there's actually a lot of data say that doxy doesn't cause that many bone dyscrasias and doesn't really cause that much tooth discoloration compared to like tetracycline. So that's my favorite myth.
Honestly, because like I said, pediatrics is something I'm like definitely interested in, and I guess that thought process is like realizing that's kind of a thought process that is, I guess, to like parents is a scary thought process, but at the same time, it's a necessary thought process where it's like you said, like risk benefit. Do we risk a short-term danger or a long-term danger, right? And so,
Mhm.
yeah, I guess my question is then would be like, or I guess like, what's like the you don't have to answer if you don't want to, but what's like the hardest decision you had to make when it came to antimicrobials?
Hardest decision I've had to make. Um, so I think like, okay, let me set the stage. So in like MRSA infections, particularly like bacteremia specifically is more so what I'm referring to. Very often, like you have a handful of agents, right? So your first thought is vancomycin. If it's resistant to vancomycin or like has a specific MIC of like two or more, we go with daptomycin or linezolid. And we actually had this like we had a patient who like wanted to leave and we had to sit there and like basically discuss with her the options because she was like pregnant and wanted to go home, but had a risk of like, you know, I'm always concerned when there's a baby involved because I don't want to hurt them with my drugs, but I also don't want them to get her with the bacteria. So I think like basically like having to sit down with like the prescriber and the patient and say like, okay, these are our options and we can go through them, but like the literature feels sparse sometimes and you get nervous that you're going to hurt a kid. So I think for me, it's those things where I don't have a lot of data to back it up. Like, of course, if I have a guideline and LexiComp says something, I'll do it. But I think it's scarier when you don't have that data. But I think the most important part to recognize is like really those types of decisions should be made in conjunction with the prescriber and with the patient. Like we should be giving everyone a voice in that discussion so that we understand like what the patient wants and what the prescriber feels is the best like risk benefit ratio for them, and we're just there, like we're there to help facilitate, have these discussions and like provide evidence where necessary.
There's some rapid fire questions that we had. What's your favorite lecture to give at
Oh,
MSOP?
meningitis/CNS infections, because it sounds cool to say that I teach meningitis.
Dang. And then continuing off that, what is your biggest pet peeve as a professor?
I think when students like feel afraid to ask for help. I
Mhm.
think like for me, one of my philosophies is like I know that ID can be very intimidating. I too was intimidated by ID. So I try to be like approachable and I try to let students know like this is a safe space. One of my pet peeves is like not asking questions or like not letting me know if you're having a hard time because I want to help you and I want to like work with you, but I can't know if you never tell me.
Mhm. Yeah. One last rapid fire question. If you weren't a pharmacist, what career would you do instead?
I think that probably I would be teaching still, but I'd probably be like a music teacher or chemistry teacher or something like that.
Mhm.
Yes, that's fair.
Yeah.
Yeah.
And then finally, last question, just to wrap everything up. What advice would you give pharmacy students that are interested in going down kind of the same path you went of um,
Mm.
pursuing becoming an infectious disease pharmacist?
Yeah, I think unfortunately there's not like an ID pharmacist student society to join. But I think something that's really important to remember is that ID is literally in everything. So whether you're in like a family practice, whether you're in internal medicine, whether you're in the MICU, on transplant service, like anywhere you are, there's probably someone with an infection, and probably you can, at least participate in like the antimicrobial stewardship aspects of that. So I would say like making sure preceptors know what your interests are, letting them know you're happy to participate in like vancomycin dosing and aminoglycoside dosing early on, getting involved in research projects. But most importantly, just like trying to engage with infectious diseases, making sure, that you're meeting your normal rotation goals. But, always trying to interface it wherever possible and just like connecting with people who've already been on that path to see like what steps they took too. But yeah, for me, it was just trying to pick up projects and more ID things, even though I didn't realize it was what I was going to end up in.
Well, that concludes our fantastic interview with Dr. Akbo. Thank you so much for taking the time to chat with us today. We hope you enjoyed it as much as we did.
And to our listeners at home, we hope you gained some It's some wonderful insight. I definitely learned a lot, especially about infectious diseases, and also definitely made me a lot less scared of infectious diseases. And
Good.
it's just overall, it's great learning about it, how kind of when treating the patients, the importance of kind of risk to benefit ratio, just kind of just trying to take account of everything. It's still daunting, but less daunting. But honestly, it sounds fun. But yeah, so for our viewers at home, let us know what else you want to see on the podcast, and we'll see you next time.